Today what I'm discussing is a glucomantor outpatient study. As you know, many people with diabetes are poorly controlled, both in the hospital as well as in the outpatient arena. Nobody really knows how to control them well. Patients live alone with diabetes day to day, and they get very frustrated. So they start on one pill and they fail it. They start on another pill, they fail it. They start on 3 pills, they fail it. And then over time, they get very frustrated, and then they're put on insulin, and then they fail that also. They fail one shot, and they got mealtime insulin, they fail that. And so the system's broken. And the reason why is people need guidance on what to do, especially with insulin. Insulin can get everyone to near goal very quickly. It works very well, but you have to titrate it. What we have done is developed an automatic titration of glucose or titration of insulin to get glucose to target. And this way, if you're out of control, in this case we did glucomantor sub-Q, which is a outpatient automatic titration feeding back to the patient. The patient uses a TelCare meter with a Verizon chip that goes right to the cloud. That comes into a computer-based system with the insulin amount, and then we automatically adjust the insulin. In our study, we have 42 patients through 3 months, another 10 patients through 6 months. These people had diabetes for 17 years, upwards of that. They were on insulin, taking 40 to 60 units a day, but not at goal. We're able to take them from a mean A1C of 10.3 down to an A1C of 7.6 with 0 severe hypoglycemia. And the way this happened is the blood sugar goes to the cloud automatically. It comes back and feeds them information on what to do. It comes back to whatever way they want. If they want it on their text, a phone, on a smartphone, if they want to email, if they want a telephone call, it does the whole system, and we bring them right down to normal. At 6 months, we're down to 6.8. So, but we don't have, we only have 10% of the cohort down there. This is not an insulin pump, this is an insulin titration. Most insulin is given by insulin pens. So you have a basal and you have a bolus for meals. And so this is all right now using a pen-based therapy. In these, in our case, 80% were type 2, 20% were type 1. And the reason, the outcome from the patients is they say it worked, that you got us to goal. I feel better. This is the first time anybody's ever paid attention to me to try to guide, to help me. Now, you can do this individually if you haven't come back weekly to the office, but you can't, nobody can afford the time doing that. Doctors don't have time to take phone calls. They are there 15 minutes every visit, you know, and you can't bring them back weekly. But if you use technology, we're using a Verizon chip. It goes right to the cloud with the TelCare meter. We're working on pens to go to the cloud too, the dosing. Right now we have to assume they're taking their dose, and then we verify that with them on each message going back to them. This can apply to all diabetes patients. In general, we're doing it with insulin, but we're working on an outpatient piece to pick the right medications based on their weight, their A1C, the duration of diabetes, their kidney function, other comorbid functions. Also on do they have insurance, do they not have insurance, what type of insurance, so we could pick the least expensive drugs to get them to goal without any issues and without any weight gain. But we're doing it right now with insulin because obviously insulin works. And what drives costs, 20% of the people with diabetes costs the system 80% of the total cost of diabetes. So you really want to take these people poorly controlled and manage them. And this is why we did this. And we were able to get them to goal within 6.5 days. It's quite impressive. What it will be is we will embed this in all of the EMRs. Docs deal with their EMR in front of them, so it'll all be right there for them, and we'll embed it in all the EMRs, and so all docs will have access to it. And then eventually, this is also, we've been using this in hospital-based systems, and the hospitals are in essence controlling the docs because they're buying all the practices up. So you have this, and so you really got to, in the hospital system, say, we need to take care of these people with diabetes. We need to take care of our outliers. We can't tolerate with anybody with an A1C above 9. We get punished, so we need to bring them down.